Hello, I'm honored to be part of the 70th anniversary celebration of the discovery of REM sleep. And while I'm going to try to discuss some of the newer work related to REM sleep and mental disorders, I do need to start with some history. Well before REM sleep was identified and characterized, dreams were a major focus of psychiatric treatment in that they were thought to represent a window to the unconscious. So it's not surprising that the elucidation of the physiology of REM sleep gave psychiatrists an opportunity to explore the neurophysiologic mechanisms for psychiatric disorders. Some of the first investigations into REM sleep and psychiatric illness were in relation to schizophrenia, since psychosis shares many features with normal dreaming. And one of the first studies done in this area was done by Bill Dement, who published in 1955 a comparison of REM sleep in schizophrenics to normal controls. And those normal controls happened to be medical students. He found that there was really no difference in the rapid eye movements themselves, but he did find differences in dreaming mentation in that schizophrenics more frequently reported dreams of isolated objects hanging in space and without much action. So the poverty of content that was evident in their waking mentation also occurred in their dreams. A bit later in 1964, Al Rechtschaffen, one of my mentors, did a study of schizophrenics who were acutely psychotic and recorded their waking EEG, EOG, and EMG, which I'm sure was quite challenging, and compared it to REM sleep parameters. And what he found was that there was really no evidence that psychotic cognitions or the psychotic state during waking was similar to REM sleep in dreaming. I think the next big breakthrough was when David Kupfer reported that people with major depression had a more rapid onset of rapid eye movement sleep. And this really set the stage for many, many studies looking at sleep architecture across a broad range of psychiatric disorders. And in 1992, I had an opportunity to work with Chris Gillen, and we did actually one of the first meta-analyses that was done in psychiatry of sleep and psychiatric disorders. And we found 171 studies of a little over 7,000 subjects comparing sleep architecture in acutely ill psychiatric patients to healthy controls. And what we found was that pretty much across the board, all psychiatric disorders showed decrements in total sleep time and certainly disruption of sleep across the night in terms of reduced sleep efficiency. But it was really the patients with mood disorders that showed the most significant alterations in their REM sleep parameters. So reductions in REM latency, increased REM density, increased total time spent in REM sleep, and increased REM percent of total sleep time. There have been a couple more meta-analyses done since that one. One in 2014 by Arfgen that looked specifically at major depression, and again found that REM sleep parameters and sleep efficiency were most affected in major depressive disorder. But in this study, and similar in the one that Dr. Gillen and I did, there really wasn't any ability to actually diagnose a patient based on their sleep architecture. And it was very difficult to really distinguish one group of psychiatric subjects from another. And then Chiara Baglioni published another meta-analysis in 2016, again, looking at a broad range of psychiatric disorders, and she grouped sleep variables into three domains of sleep continuity measures, sleep depth measures, and finally REM pressure measures. And that included REM latency, REM density, and duration of REM sleep. And what she found was that patients with affective disorders, both major depression and to some extent, maybe seasonal affective disorder, also PTSD and borderline personality disorder, all showed evidence of increased REM pressure. And certainly people who have post-traumatic stress disorder or borderline personality disorder often have comorbid depressive symptomatology. Next, want to mention some work that I had the good fortune of doing with Niels Rottenborg and Stephanie Jones, looking at an animal model of a mood disorder. And that was some work we did with migratory sparrows as a model for bipolar disorder. So there's a lot of similarities actually between migration in these animals and probably others and bipolar disorder, particularly the manic component. So there's a seasonal component in that these birds migrate in the spring most intensely and again in the fall. People with bipolar disorder are very seasonal and they tend to have their peaks of manic episodes in the spring. There are sleep and rhythm changes both in bipolar disorder and migration. There's an increase in activity during the manic or migratory episodes, along with increases in goal-directed behaviors and impulsivity. And we showed all of these things in the migratory sparrows, and including the fact that there are genes expressed in migration that have also been implicated in bipolar disorder. But in terms of sleep, we also found that the REM sleep changes during migration were similar to those seen in mood disorders, and that is that REM latency is reduced, as seen down here on the left. And then there's an increase in REM amount during the early part of the night. And as you can see here, these birds slept a lot less during their migratory period than during their non-migratory period. All right, so REM abnormalities are quite prominent in mood disorders, particularly major depression, bipolar disorder. How does REM sleep relate to treatment for major depression? And in particular, is it, I want to review some of the evidence for REM suppression as a prognostic factor for treatment response, and also whether manipulations of REM sleep may be useful for treatment of depression. And again, going back to some of the earlier work that was done by David Kupfer, and I think these studies were quite important, and it's unfortunate that it's been kind of neglected in the scientific literature and work more recently, and that is that suppression of REM sleep during the first days of treatment with antidepressants is predictive in many cases of an antidepressant response. And the reason this is of great interest, I think, is that one of the problems that we face in psychiatry is that when we try to choose an antidepressant for a patient, a lot of it is trial and error. We don't have really good ways of figuring out which drug is going to work for which patient, and often have to wait for weeks of treatment until we see whether there's an adequate therapeutic response. So in this study, Kupfer studied patients with major depression at baseline, and then the first 2 nights, and then later on during the 3rd week of treatment with amitriptyline. And what he found was that patients who responded well to the drug in terms of improving their mood showed significantly greater REM sleep suppression on the first 2 nights of treatment with the drug. So prolonged REM latency, reduced REM time, reduced REM percent, and reduced REM activity. Chris Gillen did a study shortly after that in a small number of hospitalized depressed patients, but he studied them for many, many nights, night after night, and treated and studied them before, during, and after treatment with amitriptyline. And similar to the Kupfer findings, he also noted that greater reduction of REM sleep on the first 2 nights of treatment was associated with a better antidepressant response. But moreover, he found that when the amitriptyline was abruptly discontinued, that greater REM rebound was observed in patients who had responded to treatment, but not in the non-responders. So again, the ability of a REM suppressing antidepressant to suppress REM sleep in a person with depression is somehow related to their treatment response. A more recent study by Leckinger looked at REM density at baseline, and he studied severely depressed patients who were either randomized to given a psychotherapy interpersonal therapy or pharmacotherapy with either an SSRI or an SNRI for 4 weeks. He found that while both groups had an antidepressant response to treatment, that in general that the subjects who had better sleep at baseline based on a Pittsburgh Sleep Quality Index had a better response to either treatment. But the responders to the medication, the better responders had significantly higher REM density at baseline, but there was no relationship between REM density and response to interpersonal therapy. So if REM sleep is related to depression and changes in REM sleep seem to correlate with treatment response, what do manipulations of REM sleep do? And again, I think the really classic study was done by Jerry Vogel in the mid-1970s, where he had patients with depression in the sleep lab for 3 weeks, where night after night they were subjected to REM sleep deprivation by repeated awakenings. And what he found was that patients who had awakenings during REM sleep that effectively reduced their REM sleep amount had a better antidepressant response to patients who were simply given awakenings during non-REM sleep. And that followed up, of course, studies that showed that total sleep deprivation is effective in treating depression in many cases. So what is the antidepressant mechanism behind sleep deprivation, and particularly total sleep deprivation? Is it REM suppression, or is it an increase in homeostatic sleep pressure? So again, arguing in favor of REM suppression is the Vogel study I just mentioned, and also the fact that most antidepressant medications suppress REM sleep. Not all of them, but most of them do. Certainly tricyclics, MAO inhibitors, SSRIs, and SNRIs. On the other hand, there's evidence that increasing homeostatic sleep pressure may help improve depression. Slow wave sleep rebound is correlated with a treatment response. An increase in the delta sleep ratio. So more delta sleep or slow wave activity in the first non-REM period versus the second non-REM period is associated with a better treatment response. And again, this is the classic Borbet model that with the idea that increasing homeostatic pressure, which is what sleep deprivation does, leads to a better antidepressant response. So we did a study, and of course, recovery sleep results in recurrence of depressive symptoms. So we did a study looking at slow wave deprivation a few years ago. This was with Eric Lansness, where we took people who were clinically depressed and medication free, and we had them in the laboratory for a number of nights. And on one of the nights, we subjected them to slow wave deprivation through acoustic stimulation for one night. And we didn't tell them which night it was, and they weren't really good at figuring out which night it was either. And the first thing is that we were able to significantly decrease their slow wave activity as seen here. So this is their slow wave deprivation night. This is the slow wave activity across the night, across the non-REM episodes. And we also see that during the recovery night, following the night of slow wave deprivation, that there was a rebound in slow wave activity. Here it is again. So we didn't totally eliminate slow wave sleep, but certainly decreased it. And what we found was that the night of slow wave deprivation with acoustic stimulation did decrease the depressive ratings, as reported by the subjects themselves, as well as by raters blinded to the intervention during the night. But more interestingly, we found that the reduction in depression was not only correlated with the slow wave activity rebound on the recovery night, but also the suppression of REM sleep on the deprivation night. And so when we looked at that more closely, again, here we see that a decrease in REM percent on the slow wave deprivation night correlated with the antidepressant response. And the prolongation of REM latency on the recovery night was correlated with the antidepressant response. And finally, the slow wave activity effect and the REM effects were independent of each other. So that suggested that it may not be either or. It may not be that increasing homeostatic pressure is the key pathway to an antidepressant response, nor is REM suppression a key pathway, but they may both have an effect. So that leads to the final point I want to discuss, which is, can REM sleep deprivation be a treatment for depression? As I mentioned earlier, most antidepressants suppress REM sleep. Tricyclics, monoamine oxidase inhibitors, SSRIs, SNRIs. There was very recently this year a review published covering non-pharmacologic studies done over the last half century that used recurrent awakenings during REM sleep to treat depression, and they all reported significant antidepressant effects. I think this article also pointed out that short-term REM deprivation was not associated with any negative effects on memory or cognition, but we really don't know about the long-term effects in humans. We do know that antidepressants are often used for very prolonged periods of time, years or decades, and that they tend to suppress REM sleep, at least as we recorded, without obvious negative effects. However, we do have evidence from non-pharmacologic REM deprivation in rodents, which is the work of Clete Kushida and Al Rechtschaffen, that chronic REM deprivation is lethal. So the question is, how much can we suppress REM sleep in humans without leading to harmful effects? So I think in conclusion, in terms of REM sleep and mental disorders, REM abnormalities are associated with psychiatric disorders, particularly mood disorders, that antidepressant medication effects are predicted by and associated with changes in REM sleep in many cases, something that I think we haven't maybe taken full advantage of. We know that short-term non-pharmacologic REM sleep suppression has antidepressant effects. And I think the questions for the future are, can neuromodulation of REM sleep be a useful treatment approach for mood disorders? And we are now in an era where we can do remote neuromodulation of sleep. But we need to understand what the long-term effects of chronic REM sleep suppression are. And I want to thank some of the people that I've had the opportunity and honored and privileged to work with over the years who helped with a lot of this work. My colleagues at the University of Wisconsin, and at the University of California, Irvine, and the funding support we've received from the NIH. Thank you all.